Hey guys, welcome back to my YouTube channel. And today's topic for discussion is local anesthetics or LAs. So moving ahead and going to our next slide, the first slide is about the nitrous oxide. Again, it is an important topic. Lots of questions do come on nitrous oxide. So I have made few a very small lecture for today, just talking about the important points only. So please pay attention and let's go start with nitrous oxide as our first slide. Now, nitrous oxide, we know that like we normally give it to the patients who have anxiety and visit the dental clinics, and it helps them to feel relaxed and all that stuff. So let's talk about some of the advantages of nitrous oxide. It has a ability to titrate, means you can give oxygen, then nitrous oxide, and then again you can give oxygen. It has a rapid onset. The moment you start giving nitrous oxide, you can start seeing the results. It has an ease of reversal, like if it has both rapid onset and ease of reversal. Now, like, why does it has a rapid onset and an ease of reversal? Because nitrous oxide blood gas ratio is only 0.5%. So if the blood gas ratio is low, which is 0.5% for nitrous oxide, any LA that has a low blood gas ratio will have rapid onset and recovery. And another advantage is controlled duration, means you can control the duration. What are the disadvantages? If this local anesthetic has some advantages, it will definitely have some disadvantages as well. Need for patient cooperation, means you cannot give it to children because you need you need cooperation from them, right? So that's one disadvantage. Second one is the cost. Obviously, if you will add the extra cost of giving nitrous oxide plus the treatment the patient is going through, it will add up a lot. Space, you need two cylinders to provide nitrous oxide. You need one nitrous oxide cylinder, and other oxygen cylinder that you need is oxygen, because nitrous oxide has a capacity to replace gases in the body system. So to prevent any 100% nitrous oxide in the body, we have to keep supplemented with oxygen. It has a moderate efficacy because the MAC value for the nitrous oxide is 104. So any local anesthetic that has a MAC increase in MAC value will decrease its potency and even the efficacy. The concerns are basically the occupational toxicity. What does occupational toxicity means nitrous oxide is toxic to dentists, dental hygienist, or dental assistants, anybody basically who's working around the nitrous oxide, but not to the patient. So moving ahead to our next slide, let's talk about the clinical use of nitrous oxide. As I've already mentioned, that nitrous oxide has a capacity to replace gases in the body system, so we need to supplement it with oxygen. And what is the concentration that we provide nitrous oxide? It has a concentration of 70 and 30%, means we give 70% nitrous oxide and we supplement it with 30% oxygen. So this is basically how we give nitrous oxide, and it is an important point. Questions can definitely come on this. Now let's talk a little bit about the effect of the nitrous oxide on the cardiovascular system. Now please pay attention over these 2 points. It is a weak myocardial depressant, means very weakly it depresses the myocardial system, and it also has a mild sympathomimetic effect. If you know pharma, you would know that what are the sympathetic effects? Means there will be increase in blood pressure, increase in heart rate. So it is also depressing the heart as well, and increasing the heart rate as well. So overall the effect will be negligible. So questions do come on this. What is the effect of the nitrous oxide on the cardiovascular system? And what is the effect on the respiratory system? It is a mild depressant, so it could be a concern in patients who have COPD. Moving to our next slide, let's talk about the symptoms. So once you start giving nitrous oxide to a patient in the clinic, what is going to happen? There will be relaxation, lightheadedness, tingling of hand and feet. Patient will feel some warmth. There will be euphoria, means feeling of good. Now, symptoms of oversedation, if you give it uh, more than required nitrous oxide, right, means there is no oxygen left in the body, or you are giving it like at a concentration of 80-90%, the patient will have altered hearing, visual disturbances, sleepiness, sweating, laughing, increased respiratory rate, crying, and nausea. Please, it is a very important point. Question do come on what are the symptoms of oversedation for nitrous oxide. Now, contraindicated. Where is it basically contraindicated? As I've already mentioned, that nitrous oxide has a tendency to replace gases. Anything that is, if there is any obstruction in the body system, if there is any closed part of the body, it has a tendency to replace the oxygen over there and can cause some serious effects. So, nasopharyngeal obstruction, severe COPD. Closed tissue spaces, bleomycin chemotherapy, claustrophobia, vitreoretinal surgery within 3 months. Now, let's move to our next slide and let's talk a little bit about classification. Again, it is an important classification. Questions do come on this point. And if I have to talk, it is local anesthetics are classified into amides and esters. Now, what is the most how we can remember that? I know it is hard to remember all these names. So normally students, how they remember is that amides will always contain 2 eyes and esters will come with 1 eye. So everybody has their own way of remembering them. This is how I remember them. So amides, the examples of amides are lidocaine, mepivacaine, prilocaine, bupivacaine, and articaine. And esters are procaine with the single eye, tetracaine, benzocaine, and cocaine. Now, this is a very important note that I've added. Please pay attention to this note, guys. All amides are metabolized in liver. This is an important point, and all esters are metabolized in plasma. Although there is an exception, as we have already studied that articaine is an amide, but it is metabolized in plasma, which is a site for metabolization for esters. Another point I want you to remember is that local anesthetic are weak bases. Okay, please remember that local anesthetics are weak bases. It is a very important point. Students do get a little bit confused in this, weak acids and weak bases. So local anesthetic are weak bases except benzocaine. So there is an exception as well, which is benzocaine. So now let's go ahead to our next slide and talk about, these are some, like I made this slide, all the important points. Questions can do come on this slide though. So lidocaine, this is again a very important point. Lidocaine is the most common local anesthetic that we use in dental clinics. And if somebody asks you which local anesthetics are safe during pregnancy, so lidocaine, prilocaine, and etodocaine are 3 local anesthetics that are safe during pregnancy. Important point again, guys. Mepivacaine is the least vasodilator. Bupivacaine has the longest duration. It has a duration of 90 to 120 minutes, so which is a very long duration. Articaine, as we have already studied in the previous slide, is metabolized in the plasma. Prilocaine it is the most common drug that causes methemoglobinemia, and question do come on this topic. They'll give you a question like out of the following out of the following local anesthetic, which one causes methemoglobinemia? It is the prilocaine. But another thing about prilocaine is, it is, again, as I've already mentioned, that it is safe during pregnancy. Now let's go ahead and talk about esters. Esters are used basically for topical use only, and the most common one is the benzocaine. Cocaine is the only LA that vasoconstricts. So another point I want to talk about is that since it causes vasoconstriction, and epinephrine also causes vasoconstriction, you cannot give cocaine and epinephrine together. If a patient comes to you and he's already high on cocaine, you cannot give that patient epinephrine, because they both vasoconstrict, so the effect will be very high, and there are chances of heart attack. There are good chances of heart attack, and especially in first 24 hours. So this is basically a drug-drug interaction. So remember this point, guys. So we now let's go moving ahead, and before going ahead and talking about these calculations, I want to talk about the local anesthetic cartridge. Now, we all know that if you all work in a dental clinic, we know that lidocaine or any other LA comes in a cartridge. And what is present in that cartridge? Like, what are the contents of that cartridge? So, that cartridge will contain local anesthetic. It will contain a vasoconstrictor. Vasoconstrictor could be epinephrine or levonorepinephrine. It will also contain bisulfite, which is an antioxidant for vasoconstrictor. It will also contain sodium chloride, which maintain the isotonicity of the solution. There will be sterile water. Before, obviously, now the cartridge that LA cartridge, these are the main things that cartridge contains. But in the previous ones, before they used to have methyl parabenics as well, which is a bacteriostatic, but it is no longer used today. So only things that come in a cartridge are the local anesthetic, vasoconstriction, metabisulfite, which is an antioxidant for vasoconstriction, sodium chloride, and sterile water. Now, why do they add vasoconstrictor in a cartridge? Now, basically, the cartridge, the vasoconstrictor increases the depth of the anesthesia. It also increases the duration, so we have more time to work on the patient, and it decreases the peak blood level of the anesthetic, and it also causes hemostasis. Now, and why do we add antioxidant, which is a metabisulfite? We add antioxidant, which is metabisulfite, to protect the vasoconstrictor. Now, if a patient who is allergic to basically metabisulfite, you can use the LA without the vasoconstrictor. And why do we add antioxidant in the cartridge? It decreases the pH of the solution. Which actually increases the risk for burning sensation during injection of the LA that contain vasoconstrictor. So we need, if there is no metabisulfite and there is a vasoconstrictor, it can decrease the pH of the solution and there might be some burning sensation. So to prevent that burning sensation, we add metabisulfite. Now, let's go ahead and talk a little bit about the calculations. So I made this slide. You can remember it. Remember this as it is. This is how I prefer to remember, or you can even do the calculation, and you can get these values as well. So if I have to do a calculation, so all I do is I will put 1 divided by 100,000 and which will be 0.01 milligram, and into, when I do it into 1000, it will be 10 microgram. So this is how I got my calculation, right? So how do I basically remember it? I prefer to remember it as it is. I will remember this one calculation. 1 is to 100,000, which is 0.1 milligram per milliliter, and the second one is the double of 100,000, which is 200,000, and you will half this, just make it half, which will be 0.05, and it is the half of this 10. And if 1 is to 100,000 and 1 is to 50,000, it is the half of 100,000. So I will double this, which will be 0.02 milligram per ml or 20 micrograms. So this is how I'd like to remember. I'm not very good at math, so I prefer to just remember these calculations as it is. Now, another thing I want is that one cartridge of 1 is to 100,000, how much epinephrine will it contain? It will contain 0.018 milligram. And if I have to talk about 150,000 epinephrine contains, it will contain 0.036 milligram per cartridge, and 200,000 will contain 0.009 milligram per cartridge. So I normally remember these calculations as it is. Like I do not need to calculate them because it gets easier and saves time when you are actually doing the calculation during the exam time. Now let's talk a little bit about the calculations. Now let's determine the limiting factor over here. Now, Determining the limiting factor, epinephrine will reduce the dose in the cardiac patient. So any patient who has a cardiac problem, we reduce the dose, which is 0.04 milligram. So one carpule in a cardiac patient will contain 1 is to 50,000, two carpules will contain 1 is to 100,000, four will contain this much. For normal patients, the epinephrine dose is 0.003 milligram per kg. So 5.5 carpules will contain 1.1 is to 50,000, 11 1 is to 100,000, 22 1 is to 200,000. Now, let's go ahead and talk about the next slide. So this is one of the examples that I've given, like it's just a calculation example, like how you can calculate 2% lidocaine contains 20 milligram per ml. We already know that one carpule contains 1.8 ml. This is something you should all remember. The one carpule lidocaine has 36 milligram, which is 1.8 into 20. So the calculation will come as 36 milligram. So we know that if you would know the table for the maximum dose for 70 kg patient is for a lidocaine, it is 7 milligram. So 7 into 70 will give you 490. And the number of the carpules will be 490 divided by which is the 36, and it will give you the number of the carpules, which is 13.6. Now, let's moving ahead on the next slide. Again, you can just remember these terms like this only. Determining the limiting factor for the local anesthetic, 2% will contain 36 milligram. How did this came? Same way, because one carpule contains 1.8. So 2% is 20 into 1.8. So you will get this term, which is a number 3.6. 3% is again 30 into 1.8 will come as 54. 4%, 40 into 1.8. 0.5% into 1.8 will come as 9 milligram. So these are like, you can just remember them like this only, so it saves you time when you are calculating. So this is how I like to remember. Again, I'm mentioning it, I'm not very good at calculation, so this is my way of remembering these things. Now the last slide is the anesthetic techniques. Now again, it is about the boundaries, like if you are placing your needle or the anesthesia, these are the pterygomandibular space. We know that we put for the inferior alveolar nerve, we put the needle in the pterygomandibular space. And what are the boundaries? On the medial side is the medial pterygoid muscle. So question 2 come on this one, like medially what is present in the pterygomandibular space? It is the medial pterygoid pterygoid muscle and the sphenomandibular ligament. What is lateral to the pterygomandibular space? Medial surface of the ramus of the mandible, and superiorly inferior head of the lateral pterygoid muscle. Inferiorly there is insertion of the medial pterygoid muscle or interpterygoid fascia. Anterior buccinator and posterior parotid capsule. So a question can come like, if it what is posterior to the pterygomandibular space? It is the parotid capsule. What is anterior to the pterygomandibular space? It is the buccinator muscle. So you need to remember this slide. It is again an important one from the exam point of view. So this was all for today, guys, on the topic local anesthetic. I hope this small presentation will help you guys. If you have any questions or anything, please feel free to comment. You can even follow me on Instagram under the same name, INBD Twitter, where I do post some practice questions for all you guys. Have a great day. Bye.